Hi, everybody. Thanks so much for joining us. We're going to go ahead and get started. Welcome to Healthcare Sector Participation in Coordinated Entry. This is the second of a 3-webinar series, and we're really delighted that y'all are here with us today. Hopefully, some of you were able to either join us for the webinar on August 25th, that was the first part, or have been able to watch it since then, and we'll provide links to that in this recording and slides after the fact as well. But really happy to have you here today, where we'll be continuing on with communicating to healthcare sector folks about the basics of COC and homelessness response, and particularly coordinated entry, to help give a foundation for participation across systems. So for today, in order to do that, as I said, this is the second of a 3-part webinar series. And before we wrap up, we'll remind folks what the first one was and also how you can register for the third if you're not already. So today we're going to hear in just a moment from the California Healthcare Foundation and Michelle Schneiderman specifically to give a welcome and provide a little bit of context for this webinar and the work that we've been doing with them. My name is Jillian Morchetti. I'm from Homebase, and I'll be walking through some examples of healthcare programs that already are participating in coordinated entry. And then the main event for today will be a conversation with Libby Echeverria, excuse me, sorry, Libby, who's from Valley Homeless Healthcare Program in Santa Clara County. And she and I will be talking about all the ways that program is participating in that community's coordinated entry system. And there'll be opportunities for you all to ask questions of Libby as well. So that's the plan for today. We will be providing these slides after the fact, as well as links to some other resources, so please don't worry about that. And with that, I'm going to turn it over to Michelle to welcome you all here as well. Michelle.
Thanks, Jillian. Good morning and welcome. Hope you guys are getting a chance to eat your lunch while you're listening to us today. I'm Michelle Schneiderman, Director of Advancing People-Centered Care at the California Healthcare Foundation. For those of you not familiar with CHCF, we're an independent, not-for-profit philanthropy working to improve the healthcare system for Californians with low incomes and people not well served by the status quo. Our priorities are to get everyone covered, deliver care better, and make care just. Excuse me. Last year, CHCF launched work to improve healthcare for people experiencing homelessness, promoting care that's responsive, person-centered, and focused on the integration of physical health, behavioral health, and social needs. Providing effective care to people experiencing homelessness requires the healthcare system and homeless response systems to build trust and come together in new and meaningful ways that leverage one another's strengths and resources. In that vein, CHCF commissioned Homebase to do some work to demystify the homeless response system for our healthcare partners and to report on how information sharing between the two sectors, healthcare and homeless services sector, is happening in California today. We've published that work on our website, and as Jillian said, today are presenting the second of 3 companion webinars to those reports. We hope you walk away from this presentation with a better understanding of what cross-sector partnerships can look like, and the partnership opportunities your organizations can lean into to improve care and ultimately end homelessness in California. And with that, I will pass things back over to Jillian, Directing Attorney for Homebase.
Thanks, Michelle. I'm sorry, I just was told maybe the slides aren't sharing properly, so I'm just going to stop and reshare them real quick so that we make sure you're seeing what you should be seeing. All right, so you should be seeing this was a Homebase slide. Am I? Okay, great, thanks. Sorry about that, Michelle. Sorry, I didn't realize your slide wasn't showing when you were speaking. So thanks so much, Michelle. And as always, thank you and California Healthcare Foundation for your partnership on this work. Homebase is an organization, a nonprofit that works, has been working for 30 years or more with communities around California and also around the country to improve their responses to homelessness. And for the past several years, we've also been focusing a lot, not exclusively, but among our work on this kind of homelessness and healthcare cross-system coordination work. And I specifically have been doing this work for about 7 years at this point, just that intersection work. So I'm really excited. I also do a lot of work with coordinated entry. And so I'm especially excited about this project and to be able to help provide some basic foundational information about coordinated entry and homelessness response to healthcare sector folks so that we can help build those partnerships that Michelle was talking about. So really, really excited to be here as always, and appreciate the partnership tremendously. So before we talk about specifics of healthcare programs that are working on coordinated entry, and then shift especially to talking with Libby about her program, I want to do a little bit of a refresher. I know many of you were probably on the first webinar that we did, or hopefully have watched it or will watch it, where we really laid the foundation for what homelessness response looks like, the basics of that, the basics of coordinated entry, and then some key opportunity areas for participation. So I'm just going to relatively quickly walk through that because I don't want to redo that webinar that we did, but I think it's helpful both for folks who weren't able to join for that webinar and also just as a refresher because this is new information for many of you. And so just to kind of reset the context. I do want to mention that I mentioned that we have a Q&A at the end after Libby and I have a conversation. So please put whatever questions you have at any point during the lead up to that. There's a Q&A box that's separate from the chat box. So if you do have questions for Libby, especially once we get to having a conversation with her, make sure you put your questions in that Q&A box rather than the chat so that we don't miss them and we're able to get to as many of those as possible. You're obviously welcome to use the chat as well during the course of this to connect with each other, but if you have questions, just note that Q&A box specifically. So getting to the kind of why are we here, some of the very basics of why we're here. I think if you're on this webinar, you're pretty well convinced that there's a connection between housing and healthcare, hopefully, at least as the needs. But we really want to focus on this sort of partnership building because we also know there is a disconnect between the needs and folks' access to healthcare. So for a lot of reasons, right? Because there's a lack of knowledge of healthcare resources that are available and how to access them by both clients, folks who are experiencing homelessness and those who work to help them. There's a lack of accessible behavioral health services in many communities. There's a lack of just the ability to get access to things, including because of reasons like transportation or other logistical reasons in addition to that. And there's lots of other reasons that folks are not either able or particularly excited to engage with the mainstream health system if they're experiencing homelessness, and especially if they have been for quite some time. So adding to that, there's also just a disconnect between the systems themselves, right? They were made for distinct purposes. They often operate completely separately from one another. And so bridging that gap between homelessness response and healthcare is really important to make sure that we're both improving healthcare outcomes or health outcomes for folks experiencing homelessness. And because of the connection between healthcare and housing, right, that we're also increasing housing outcomes as well. So as I promised, this will be a quick refresher of the fundamentals of coordinated entry, which is a key aspect of homelessness response. And then I'll and some of the sort of main opportunities that healthcare stakeholders can sort of plug into coordinated entry before we shift to some concrete examples. So just for a few minutes, we'll do reminders of what coordinated entry is, right? It's essentially the process that each COC or continuum of care, which is the umbrella organization that homelessness response happens under, to ensure that folks who are experiencing homelessness are both prioritized for resources based on the severity of their need and then matched to available resources that are most suited to them and their needs. And the primary purpose of it, as distinct from, when different programs are all operated separately, this is a more coordinated effort, right? The primary purpose is to make sure that housing resources and related resources are allocated equitably and also as appropriately as possible. So just to sort of remind folks of what there's 6 essentially phases of coordinated entry or key components. So there's the point at which clients basically who are seeking, so folks experiencing homelessness that are seeking housing or services, make contact with the community's homeless response system, right? They're entering the coordinated entry system. Everyone who enters the system is then assessed in a consistent manner using uniform decision-making process and standardized assessment tools. That's the goal, right? So that we have consistency across. That everyone who's assessed is then prioritized for housing and community resources based on their needs specifically. And those needs and like level of vulnerability, severity of need are essentially captured by factors that have been agreed upon by the continuum of care as the way to sort of across the board, again, prioritize folks based on need for resources as they come available. As resources come available, clients that are at the top of that priority list based on their need are given a choice to accept resources that have become available for which they are eligible. And then if the client does accept that match, they're then referred to the program that holds the resource that became available for them, and ultimately placed into that program and ultimately into housing. So that is a vastly simplified version of what coordinated entry looks like. But again, wanted to make sure we're sort of refreshing folks on the basics before we get into some details. So again, if we're thinking about the different sort of phases of coordinated entry, and these are the last two slides of sort of refresher before we move on to some concrete examples, but there are lots of different opportunities for healthcare providers to participate in coordinated entry. So things like helping make sure you're connecting patients that you're working with who are potentially eligible for homeless assistance and housing, making sure they're connected to the coordinated entry points that you can serve as a coordinated entry point, which can look like either in the form of like street outreach or in a physical location, helping to review or select or develop the assessment tools that are used to then gather information about folks that is used to prioritize people. Some healthcare providers you can provide space for those assessments to actually take place, help administer them, and also work with the coordinated entry system to make sure that among the factors that are considered for prioritizing folks, that key health considerations are part of that. And as well as sort of in the sort of second half of the process, when we're getting to the point of matching and referral and placement, there's additional opportunities for participation, including things like participating in case conferences that can be used to match with resources or to kind of adjust prioritization or better understand clients and their needs, to help support folks once they're housed by making sure they're connected to health resources and other things that are really useful and necessary to make sure folks stay stably housed, and also things like helping clients procure documentation that can sometimes be necessary. All right, so the new stuff. Thank you for obliging us as we sort of provided refreshers again, and maybe that was new for some folks, in which case I apologize it was so quick, but again, we have a whole webinar you can look at after this too to kind of get even more information about all that. So we're going to shift and just give a couple examples of some successful healthcare homeless system partnerships, partially because the ideas are helpful, I think, to kind of make concrete the examples I just provided or the opportunities, and also to kind of remind folks that we're not just talking in theory. Like the fact that I'm telling you, hey, you have all these opportunities, is not just me wishful thinking, right? Like there are people and programs that are making this work and are making this happen. So just wanted to give sort of a sampling of those so you can kind of grasp a little bit more specifically like what this participation can look like. So we just have 2 slides worth of some examples I'm gonna touch on, and then we'll shift over to talking to Libby to hear about specifically what her program partnership looks like. So we have a couple different examples of programs that are serving as in different states that are serving as coordinated entry access points. So that means they're identifying and actually completing the intake process for folks who might be eligible. In Washington State, again, kind of connecting to making sure folks are getting connected to the coordinated entry system in the first place. Washington State provided a training that was the basics of COC and coordinated entry to folks who are in state psychiatric hospitals working in discharge planning, so that they can make sure they're identifying folks that they're working with to discharge to see if they're eligible for homeless assistance, and if so, to make sure they're getting connected to the entry points for the relevant coordinated entry systems. We have a couple examples of managed care plans that work directly with continuums of care to make sure their plan members are connected to the coordinated entry system if they're eligible for the types of assistance available. And for LA Care, the example here, they've worked with the COC specifically in the context, or for example, in the context of COVID-19 shelters. So folks that were put into non-congregate shelters to help protect them from the pandemic, making sure that their plan members were getting connected to services that they needed. And then United Healthcare has done sort of data matches with various COCs around the country to identify overlap patients and sort of work with each other to make sure their members are connected to homeless services and vice versa. And then finally, just wanted to provide this is again related to system entry, and I mentioned street outreach can be part of that. So there are lots of examples of street medicine programs or homeless outreach teams that incorporate in some way staff from hospitals or clinics or community health centers. Often it's healthcare for the homeless programs. So being part of those, being embedded in those outreach teams to help connect folks on the street to coordinated entry, and also to make the initial connections to healthcare services as well. And then just a few additional examples before we shift over to talk with Libby. So again, we have an example here, Baltimore Healthcare for the Homeless, that actually assisted the COC with developing a locally, like a customized assessment tool. So many communities use, communities can choose what assessment tool or tools they use. Many use a kind of somewhat standard form or a similar form across called the VI SPDAT, some folks might have heard of, but some communities have developed their own customized tool. And in this case, the Healthcare for the Homeless program actually worked with the COC on creating that tool, and also provides training for COC staff to help use it, so that it's, again, got relevant health factors in it, and also folks are trained to use it consistently across the board. Albuquerque Healthcare for the Homeless program is an assessment location itself for the CE system, and they have trained specialists to complete the assessments with clients at those locations. There's a couple examples from Richmond, Virginia and Minnesota of healthcare providers that are participating in case conferences to actually make sure that to help match prioritized households to resources that are most appropriate, and also to then make sure that folks are supported and moving towards housing itself. And then the final example we have here is from Houston, and that coordinated entry system partners with 3 different healthcare for the homeless programs to help make sure clients are getting referred to health clinics and dental services, mental health services, other health related services, and housing as well. So again, I know that that's not a deep dive into any of those programs, but we wanted to kind of give a sense that around the country, there are lots of examples of successful partnerships in this space where healthcare sector stakeholders are working directly with the continuum of cares, their relevant continuum of cares coordinated entry system, and that participation can look very different in different places. So there's lots of different places to plug in. So the final thing I just want to mention as a kind of segue into talking with Libby about her program specifically is that in a lot of ways, COVID-19 and the response to the pandemic has been a sort of catalyst to really galvanize partnerships between homeless systems and healthcare systems. And that has looked very different. It's manifested in a lot of different ways. But what I want to talk about specifically, because it most relates to coordinated entry, is that because people who are experiencing homelessness were and are among those most vulnerable to severe COVID-19 illness and even death for lots of overlapping reasons, many communities and the U.S. Department of Housing and Urban Development, which is a major funder of homeless response assistance, really promoted this idea of a lot of COCs adjusting their coordinated entry prioritization schemes to better incorporate COVID-19 risk factors. So that, and in a lot of places that looked like simplifying things so that the risk factors for severe COVID-19 illness sort of became the prioritization factors for coordinated entry. And in some places, it was just incorporating them into the prioritization scheme. So basically just recognizing that this pandemic meant that people were uniquely vulnerable, and making sure to incorporate that vulnerability into the overall prioritization to connect those most vulnerable in this moment in time to the housing resources available. And of course, as part of that work, in many places, various different types of health stakeholders were involved in that process, public health departments, local healthcare for the homeless programs, and other stakeholders as part of that. And the reason I bring this up is because it does really fit into where there are some opportunities because of this unique experience we've all been living in this last year and a half plus, that really impacted coordinated entry directly. But I know Libby will speak at some point too about the sort of impacts that the pandemic had on the partnership across systems as well. So before I shift over, I just want to make sure, because I am not as able to see the Q&A and chat, if Julie, if there's anything we need to cover or address before we shift over.
I think there's one that might be relevant right now. You talked about public health departments, and one of the questions was, are there examples of local health departments who are working with COCs and coordinated entry?
I don't know that I could rattle off like specific public health departments right now, but I know that on the coordinated entry front, there are, like, I'm doing a lot of work and have been for the last year and a half in Sacramento, for example, and the Sacramento Public Health Department is really involved in their COVID response, which is what I've been supporting them on, and the homeless response systems COVID response work and their rehousing efforts. And so that connection has been there, and so has, in the same way that's on the slide right now, has definitely impacted the way that the COC adjusted their coordinated entry prioritization to incorporate the risk factors from COVID. As far as other ways that public health departments are participating in coordinated entry? That's a really good question. I don't have off the top of my head like explicit answers. I think it's been so focused on more, especially in California, on more the emergency response to COVID. And so I think that's more where the connections are happening as opposed to directly in other aspects of coordinated entry for now. But again, I think it lays a really good foundation, sort of like demonstrating the benefits of that cross-system collaboration. And so hopefully we'll continue in the future. And I don't know if Libby, you have any idea about the Santa Clara County Public Health Department in that vein, but we can also try to answer that question as well.
Yeah, exactly what you said. For us, we had like a command center for for the response to COVID for the homeless population, and it was public health and VHHP and Office of Supportive Housing in the city of San Jose. And so we all worked together as an integrated team to figure out how to respond to this and how to protect our population. But public health was more in the role of advising us about, shelter sanitation or like COVID screening and things like that, as that they were not part of the COC or any kind of assessment.
Thanks, Libby. And with that, I kind of jumped the gun on Libby and made her answer your question before I let her introduce herself. So thanks for your flexibility there, Libby. So we're going to shift now to actually focus specifically on Libby and her program, Valley Homeless Healthcare Program. So Libby, thank you so much for being here. I'm really excited that you're here to share with folks because I know your program works with the coordinated entry system in a variety of different ways. So it'll be a really great way for folks to hear about more specifics about kind of the different individual ways that you can participate in coordinated entry. So to kick us off, would you mind just introducing yourself now that I'm actually letting you in your program a bit, and kind of just give a sort of overview of the program as a whole that you're here to talk about?
Yeah, absolutely. So I'm Libby Echeverria. I'm a licensed clinical social worker, and I've worked for VHHP for almost 15 years. And I was a clinician for a long time. Now I'm a program manager. And I see that a lot of my healthcare for the homeless colleagues are on this. So over the years, we've turned into a very large program. We provide primary care, psychiatric care, treatment for addiction. We provide social work. We have legal services. We have outreach. We have a backpack medicine program. We have a medical respite. We have 14 clinic access sites. 4 of them are brick and mortar, and the rest are all through our mobile medical units that go to different places so that, it's all about access. And we're a geographically very large county, so our buses go kind of all over the place. And the COC here, just, to give you context, is run by the Office of Supportive Housing here, which is also, so we're part of the county. We're under the county hospital as an ambulatory care clinic, so we're not a community clinic. And also the Office of Supportive Housing is a county department, not part of us. We have a close partnership with them now, but we haven't always. So we definitely went through a journey in terms of working with coordinated entry.
Thanks, Libby. I'll ask you some additional questions about what that journey looked like in just a moment. But before we get to that, could you also just sort of as a bit of an overview, kind of either list out or just briefly describe the different ways that you are participating in coordinated entry, like the different sort of spots where you plug in, and then we'll get into the details of each of those as well.
Absolutely. So it covers a lot of what you said before. So we are an entry site, and we do assessments. In our county, it's the VI-SPDAT, which is the world's worst acronym, and it stands for Vulnerability Index something. And but we do those and we put them into HMIS. We do the verification of disability and verification of homelessness once somebody is chosen for housing and needs that paperwork done. We have regular meetings with Office of Supportive Housing to advocate for the places where the VI SPID Act kind of fails to capture people. And we've been part of their discussions on how to redesign that process. Yeah.
Great, thanks, Libby. So this is so going to, you described like the journey of getting to the point where you are now as far as participating in coordinated entry. So could you describe a little bit, because I think, many people on this call are likely not even on step one of that journey, but are kind of learning about how to get that started. So it would be great to hear a bit about like both the first step and also kind of what led to that first step. So if you could talk a little bit about like how you began to start getting involved, and by you, I mean the VHHP,
sure. Yeah.
right? Like
Yeah.
how you started to get involved in coordinated entry.
Well, prior to coordinated entry, we had been, we were still providing homeless healthcare, and they were also very small, and they were administering whatever vouchers they had through the housing authority, not necessarily supportive housing. And so, we were always like, oh, these are the guys who are providing housing, and we're the ones providing healthcare. It was very separate, but we were still considered a partner. And at that time, it was a very subjective process. They just kind of give some vouchers to each agency and say, choose who you're going to give them to. And it was kind of a disaster. So when coordinated entry first started, we were in on the ground floor. Since we were sort of with a pre-existing relationship, but it was just like, we were one of the agencies. And so we got trained in how to do the VI SPID Act, and our social workers have been doing that. That's their role. So for years we did that. And then we would go, like if we had for instance, a patient on the street who had a terminal illness, but didn't have a lot of other risk factors, we would advocate like crazy to get them housed. But the problem is the VI SPID Act does not have any way to reflect that. And these people were not prioritized to the top. And so all we really could do was bang our head against the wall, and for Office of Supportive Housing to feel like they were frustrated and failing too. I mean, because they couldn't provide workarounds to the VI SPID Act. The whole point of coordinated entry is to like make it a level playing field for everybody. So that was pretty much, how it went for a long time. And then we started a closer partnership with them around the time that they really launched their permanent supportive housing initiatives and makeover and everything. And so we started a new clinic at that time to serve specifically that group of people who were newly housed. And we had tons of meetings with them. And that's when we started doing a high number of those verification of disabilities and stuff like that to expedite the process for people to get housing. So they weren't like running around trying to access primary care physicians and not getting any response to forms that need to be filled out, that sort of thing. And we were meeting with them very regularly one of the things that we talked to them about over and over again were again, this group that were falling through the cracks, which are the people who cannot live independently. So they have dementia or something like that. And there's no place to put them. They can't live in a independent apartment, even if they have a live-in caregiver, but there's no way to pay for a boarding care or any kind of licensed facility through the subsidies that we get from HUD. So anyway, so we would advocate and try and put things on their radar like that. And then we had a pretty robust, one of the benefits to us being a assessment spot was that we generally got a ton more information than other access points. And so their score might go from, the top number for the VI SPID is 17. So that might go from a 6 that they did 2 months ago to a 15. And it wasn't like their situation got so much worse. It was that they were open with us. If you're going in for a shelter stay for a night somewhere, you're not going to tell them all about your childhood trauma and your drug use and all this business, right? But at your doctor's office where they're doing really comprehensive assessments, you're sharing that stuff. So we were able to really expedite the right people towards the top who were very, very vulnerable, but weren't necessarily getting caught. So, and then during COVID-19, it's interesting how things shifted, because we were working closely with Office of Supportive Housing, but there was still some tension in that relationship. And then once COVID hit, it was like all that just went out the window. We worked as a completely integrated team. It was all hands on deck. And the way that I think like almost everywhere, the way that we set things up were by putting vulnerable people in motels, but it wasn't vulnerable like the vulnerability index VI spit at. It was vulnerable based on people's susceptibility or vulnerability to complications or death with COVID. And so we had all these medically fragile people finally, housed in these motels. And then Osh started seeing what we'd been talking about with the people with dementia and the people who were incontinent and mentally ill and in a wheelchair, and they're like, what are we supposed to do with them? They can't live independently in a motel. And we're like, this is what we've been talking about for 10 years, but it was great that they finally saw it and experienced it. And so those conversations are more robust right now. We don't have the solutions yet, but we're working towards them. So in many ways, COVID actually was a real blessing to our system, because we are now, it's like we're one big agency as opposed to being two agencies.
I think so.
Can I just chime in a little bit, Jillian?
Absolutely.
Folks who don't have as much experience with the homeless system of care, especially folks who are healthcare practitioners, the way that the VI spit at or a lot of these prioritization tools work is that it's self-reported. So you get information about someone's experiences, their mental health issues, their substance use issues, their challenges in life, only based on their own reporting. And one of the huge benefits of really deep partnerships with healthcare is that you get real evidence-based information to help make those prioritizations. So whenever there's a healthcare provider involved, you get, as Libby said, so much more rich information about someone's experience and what they might be in need of that you don't get necessarily from self-reporting. So that was a really helpful example to kind of highlight why we're here today.
Yeah, exactly. So what our general practice is that for any new patient, we do, they see the social worker, they do a full psychosocial assessment. So they've been talking to the patient for an hour, got all their family history, got everything that's going on with them, done the mental health assessment, done the substance assessment, and then they do the VI spit at. And so, it's just easy for the patient then to answer the questions for themselves. And occasionally, while we really do have to go by self-report, occasionally a patient won't have a lot of insight. And we're not talking about like schizophrenia, where they say they don't have a mental illness, which, you have to put a self-report, even though it's terrible. It's one of the failings of the VI spit at. It's more like there's a question on there that says, did your history of trauma cause your homelessness or something like that? And they'll be like, oh no. And then, we can say, well, gosh, you just told me that the first time you became homeless was when you were 12 after your dad beat you so badly that you left the house. And they're like, oh yeah, I guess, and so it's not so much that we're, answering for them, is that we're helping them connect those dots. And
Yeah, thanks so much, Libby, and Julie for bringing that up. I was similarly kind of, again, not wanting to spend too much time on like describing the VI spit at for folks, but it is a tool that a lot of communities use, and in varying ways, and some base their prioritization almost entirely on like a VI spit at score. And so it's, if your community that you're working in is one of those, it's obviously good to familiarize yourself with the tool. But others, will use some combination of a VI spit at score, which is meant to measure vulnerability, right? Which is how coordinated entry systems are meant to prioritize folks. But then, some people will say VI spit at score, and somehow that interacts with like how long someone has been homeless or other different factors. And so, Libby, I'm glad you brought up the point of the sort of limitation, and Julie to add some of that to the limitations of that particular assessment tool, which there are going to be limitations to any assessment tool. And so I think that's another reason that we really encourage healthcare providers to participate in sort of even in kind of like just the organic way that you were describing, Libby, that it comes up in doing the work with coordinated entry, that you realize what some of those limitations are and can communicate them better. But being able to kind of so sort of see how things are going and make some suggestions about maybe this isn't the right tool, or maybe this tool should be supplemented with this other information that we can help with. So kind of both, if you're not in on the ground floor, which at this point, most places have their assessment processes or prioritization schemes like set up in some way, but they're meant to evaluate them on an ongoing basis. So you can, as a healthcare provider, really help inform like how those tools are used, how that information that's gathered is used to prioritize folks in a way that makes the most sense in terms of actual vulnerability and, you know, who needs those resources sooner. So setting it, so in addition to kind of all of what you described, which you did kind of describe a bit about how your participation has evolved already, which is great. But I am curious if there are additional, especially at the outset. I know you kind of laid out some of these already, so I'm not asking you to repeat yourself, but just if there are additional challenges that you faced in participating in coordinated entry, and it could be in any of the ways that you described, either via, you know, actually conducting the assessments, or helping folks get documentation, or the outreach piece, or any of the other parts. And because it seems like hopefully not just because of COVID, but I know that was like a big part of it. As your sort of participation has evolved and gotten better, like what were the key things that made it better? I think it is likely that if folks on this call or people that they talk to start to step into the process of hopefully wanting to participate, it'd be good to give folks a sense of like what the main challenges might be and some ways to kind of overcome those, and the benefits of, or the, you know, why it's worth persevering, and, you know.
Yeah.
Yeah.
You know, the main thing I think of when you ask that is really like, you know, what your role is and what this work is about, is that building the partnership. And at the beginning, well, for many, many years, it was, you know, we were so separate. And they were really in charge of all the housing, you know, shelters, transitional housing, permanent housing, and all the ways that was prioritized and distributed. And we really had no role at all and no influence at all in that. And yet, you know, they always were a housing first model, and they always were like, yes, you know, we have to, these people are so vulnerable on the streets, vulnerable to death on the streets. And so there was sort of like, they knew there was a medical component to it, but we were never really working together on anything. And then pushed to work together in a little bit more of an integrated way. And it was kind of a tense process to start doing that, because again, it was like this is how I perceived it. Their view of us at that time was that we were just kind of like a community agency providing some basic services, as opposed to we were like, no, we're like an equal partner to you. And, you know, we bring all of this that you don't have that you need, and you bring all of this that we don't have that we need, but we're equal partners. And that was a struggle for several years too, to really kind of build that. And, you know, that took a lot of meetings between our medical director and the director of the Office of Supportive Housing, which I will now call OSH from now on. And, you know, and then to trickle down to some of the other management and stuff, you know, and then we get frustrated. So, you know, so it was just a process. And then, you know, and it started really smoothing out. We started getting some good ability to advocate, give our opinion, participate in the processes that they're going through to revise things. But then when COVID hit, that was really what put us over the top of the mountain and got us so integrated. And it was just all hands on deck. And our emergency operations EOC, like I said, created an offshoot of themselves for the homeless response. And so that was, you know, that was us. That was called the JDOC, the Joint Departments Operation Committee. And it was just this very, very intense time. And I'm sure it was true for all of you guys, pretty much. We were working 12-hour days, 7 days a week, in absolute integrated partnership, because we were the ones medically triaging who needed to go into the hotels. They were the ones getting all the hotel contracts and the people who are going to be running the hotels and dealing with training the disaster service workers and motels, and we were providing medical oversight for the people in the vulnerable motels. And it was just like was so much deep, give and take and equal partnership. And they realized they absolutely could not do this at all without us. And we realized we absolutely cannot do this at all without them. And so it became this very beautiful, very deep integration. And I just know that's going to continue from here once we get back to regular business, but we're going to have to kind of redefine what it looks like in regular time and business.
Yeah. You mentioned at the beginning, before I let you introduce yourself, how public health had kind of been involved, at least in the COVID response. Are there other healthcare providers beyond Valley Homeless Healthcare Program and like public health that you're aware of that are also participating in some capacity in coordinated entry?
So we have a couple of other agencies that provide homeless healthcare services, but I don't think that they are entry points. I don't think they do the assessments because they're very small, and I don't think they have the staff to do that, and they don't have any like street outreach. I think and I'm not sure if the VA does it either. So I actually can't answer that question. I don't know.
Okay, that's fair. Thanks, Libby. I think we're going to shift over in just a sec to audience questions. So I'll just like my sort of final wrap up question to you will just be before we shift over to that. If we have a variety of types of health sector stakeholders, both on this and also that are hopefully going to watch it after the fact or maybe access the slides or the recording. If you had, one piece of advice for those stakeholders who are interested in learning more about their community's coordinated entry process or, taking the first steps to getting involved, what would you most like to share with those folks?
Immediately, the first thing you really need to do is to reach out to the people who are administering the COC, the people who are running it, the people who are sort of like the owners of the HMIS, which is the Homeless Management Information System, the database, and explore with them exactly what that looks like, and then become an HMIS user. At that point, once you're on HMIS, you'll be able to see some things like where the patients have been staying. So like if you can't get a hold of somebody, you'd be like, oh, they're staying at, the little orchard shelter, and then you can call the shelter and get a hold of them. It's useful to you, but also you can have your staff go through the training to do the whatever assessment is used in the county, and just kind of get in like that. Once you become a part of the COC, it's a lot easier than at least our COC, but I think most of them have regular community input meetings like once a month, and you can start attending those just to learn and then to start giving your input as a community provider, and just kind of build from there.
Great. Thanks, Libby. So I'm going to let Julie share some questions that we've been getting from the audience. But to your last point, I just wanted to let folks know that we will share a couple of resources at the end of this and as follow-up. And one of them is a sort of COC and coordinated entry 101. And at the end of it has a list of all the COCs in the state and what their websites are, so you can connect with, and where they operate, so you can connect with your relevant COC. So, all right, Julie.
Yeah, so one of the, there's two questions really that kind of revolve around the same thing, which is referrals. So let's say you talked about being an entry point, so you're actually able to do the assessments yourself. But if you're a healthcare provider who isn't part of the entry point system, how would you talk to them about referrals? And is there a registry was one of the questions. And if you're frequently interacting with folks who are experiencing homelessness, how do you connect them into this coordinated entry system?
Yeah, that's a great question. So I think basically you just have to find out where there are places that do the assessments. And it's all, pretty much all the shelters will be access points, but there will also be other places where people who live on the street can go. In our county, there are outreach teams that will do it. The community resource centers, just the ones that are out doing, they do rental assistance and food assistance and other things like that. They office, not the housing authority, but whatever kind of COC host is in your county, and just get a list of those. Or, a lot of times if you have a relationship at a shelter at all, like a manager or somebody like that could get you the list. There's usually a list on the release of information that the client needs to sign before they do the assessment, because once when they do the assessment, which usually has a lot of health and mental health and substance questions on it, pretty much any of the participating agencies can see that. So they have to sign a release, but all the agencies should be on that release.
Yeah,
Yeah, go ahead, Julie.
I was just going to say, to Libby's point, like every COC will be a little bit different in terms of how their entry points are set up. There could be a combination. There could be like one place that's a little bit more rare, like one place that everyone goes through. It could be a combination of outreach teams plus physical locations. There could also be a phone number, like a 211 that some communities use. So it really does. So the most frustrating but also true answer to a lot of these questions is, well, it depends on the COC, and also I can give you some basics. But so that's all the more reason, like Libby's, advice about a first step being to just reach out and start to get to know the COC and who runs it is really critical, because you'll get the community specific information in that way.
And the next question sort of ties into the idea of the release. So as a healthcare provider under HIPAA and some of the more broad exposure to information in HMIS, how do you balance that? And how do you, what does that mean for you when you're engaging in the HMIS?
Yeah. So HMIS is see, and you can't see what other agencies are doing, and they can't see what you're doing. The only thing you can see of each other's is what programs people are enrolled in, and what their VI SPDAT is. So it's totally not connected to kind of any EMR. We don't put any notes in it, like outreach notes or anything like that. So we're not sharing anything. The only thing we're sharing is that information on the assessment itself, and the patient has signed a release for that. And then the only other thing we do is, that's how we get our bus passes. We have a bus pass program in our county for people who are homeless, and they have to be opened to VHHP in order for us to refer them for a bus pass. So other people would see they were getting services from us. But again, they signed that release. So that's really all it comes down to for us.
I'm just going to do a little chime in for our next webinar, which goes into a lot more detail separate from just participating as a healthcare entity in the HMIS and in the coordinated entry system. We're talking next week at the same time about bigger collaboration, cross-sector collaboration, and sharing that data, sharing more deep data, and hearing from some of the communities that have been doing some of that more deep data and what they've done to be able to balance the HIPAA concerns and being able to share data to collaborate and provide better care. So just a little plug for that for those of you who want to know more. A quick question on status. So if someone is pregnant and they don't have any other children, and they're in a community that has two separate VI SPDATs, one for an individual and one for a family, how do you deal with a pregnant woman?
We do both. We put them on both lists. There's a question on the regular VI SPDAT if you're pregnant. And so we would go ahead and sign them up there, and we'd sign them up on the other list. And hopefully one of those numbers would be high enough to get them in somewhere. And then once the baby was born, we would update the family VI SPDAT. You can update it whenever somebody's situation changes. Otherwise, we have to update it once a year. But if someone's situation changes, then you can update it then.
Yeah, I think that's another question, that sort of family composition and which type, if a community has multiple assessments, that's another thing that's going to vary by community too. So in some communities, they'll ask the person, they'll kind of explain to the person, this is how the system works. Like, would you rather fill out this assessment or this one, or, you know, be considered for these types of resources with this? And then, like Libby said, some communities will offer both. And that's another thing that, again, like I said, frustrating but true, is going to vary community by community.
Yeah, I would say that most places do think it matters when someone is pregnant. And that's not going to be the only consideration, because you may have somebody who's living in their prostituting themselves and using every day and getting sexually assaulted. You know, we know who's the higher risk there, but the pregnancy does matter.
Great, thank you. Another question is, a lot of the focus is for outpatient, the intersection with the outpatient healthcare system, but there's a question about how do hospitals engage, and especially looking for examples of how coordination of care can be improved to address the continuum of care for those individuals. So in a different way than you are, but maybe your partner organization and how they're working that through.
Well, you've hit on a little bit of a bruise there. In our county, the inpatient hospitals have flat out refused to participate and say they don't have time to administer VI SPDATs. So they don't.
One thing that we've tried to help support both COCs and especially hospitals sort of think about or try to start considering is, even if hospitals are not, for capacity or other reasons, going to be able to fill out assessments, at least making sure that the referrals to the coordinated entry points are happening. So as part of working to help hospitals figure out ways that are workable for them to integrate into their discharge planning process, and like at least an identification of clients who are likely either already homeless or are likely to be homeless upon discharge, and making sure those folks get connected to the coordinated entry point. So again, there are different ways to participate. So a hospital could be essentially helping to connect folks to coordinated entry without actually doing the assessments themselves. So that would be like, gold standard as far as I'm concerned, but even just incorporating just that extra bit into the discharge planning process is something we've been trying to get. We've been hoping or like working with communities to kind of think through like what's the best way to do that. So if that's a possibility, even that would be great too for lots of places.
Yeah, and just to add, the social workers at hospitals can have similar roles for the folks that they serve as the way the social workers are working with Libby's organization. So as people are moving out, to be able to, like, if not participate in coordinated entry, know who your coordinated entry referral points are and build those relationships and flag that this person's about to be released. We want to make sure that they end up having a place to go, et cetera, et cetera. Another question is,
can I just say one last thing about that? I just want to add that more and more medical respite, also known as recuperative care programs, which provide post-acute care for people being discharged from hospitals who have ongoing high needs. Libby, and I know you all have one in Santa Clara, but more and more those programs are connecting with COCs and able to do those evaluations there. So that's just one other point of connection to the hospital.
Definitely, that's how it works for us.
And a similar question of how to engage and work with making sure local community health centers are aware of how and where to access the whole coordinated entry system and the whole continuum of care. So if you both can talk a little bit about that.
Jillian, want to take that one or?
Yeah, I think in the same way that a lot of the examples that I shared on those two slides with were obviously healthcare for the homeless programs, but I think in similar ways, community health centers generally can participate in really similar way, kind of in analogous ways. So both in terms of either connecting with, for example, and maybe even embedding with ideally like in outreach teams, for example, so that a community's homeless outreach teams incorporates maybe some of the staff from the community health center, or at least like has some connection to that outreach, such that when outreach teams are interacting with folks out in the street and they identify someone that has a health need, like being a place where that connection can be made to connect someone to primary care or doing follow-up, I think is one thing that we have seen in a lot of communities as a way that community health centers are involved. And similarly, kind of in the ways that Libby has described, and that again are on those examples, like help better understanding where the coordinated entry points are, and also just the basic eligibility requirements so that, you know, health center staff, when they're working with patients, are able to identify, or more likely to identify, this patient is someone who could qualify for homeless assistance. And so there's someone that I should make sure that I connect to the coordinated entry system, are like the basics of what I would share. And Libby, I'm sure you have things to add as well.
Oh yeah, actually that spurred a thought in me that's slightly different, which is that I would encourage absolutely everybody to get very familiar in your county with how it works, how it's decided who gets the housing, how it's assessed and prioritized and all of that, so that you're not, like, one of my biggest pet peeves in homeless care is when people promise what they can't deliver. And so people will come to me, you know, come to VHHP and say, oh, I was told you guys could get me housing. And it's like, no, we can't get you housing. Oh, I was told that because, you know, I don't use meth, but I heard if you use meth, you get housing. Am I supposed to go out and use meth? You know, we get these questions all the time. And it's like, some of it they're hearing on the street, but a lot of times they hear it from other providers who are like, oh yeah, you know, they'll sign you up and you'll get on the waiting list and you'll get it within a year. Well, it doesn't happen like that. It's not chronological. People don't just move up based on when they signed up. It's, you know, so the more you can know how it works, you can educate the clients, and then they can be empowered to then go and take care of their business in a much more effective way.
That's a really great point, Libby. Thanks for adding that. And the only small thing I'd add to that too is, in addition to, especially for the housing or the sort of more like the sort of bigger resources, or the kind of seemingly more significant, the more you know too about the other types of resources, so that even if a client, so that again, you can kind of be communicating with your patients, like even if a client for various reasons is maybe unlikely to get prioritized highly enough to get housed in a certain amount of time, they might be able to, via the coordinated entry system, get connected to other types of resources that might still be helpful to them, even if it's not literal housing. So
and then we have a couple just comments, and I will go ahead and put them in the answered so that the rest of the audience can see those. But just to say in general, one is about, maybe Libby, you can talk a little bit about what HMIS doesn't collect, and the issue about sort of how do you make sure that those who aren't participating in the system get information about people and then into the system, and then also the shortcomings of HMIS. And then the other comment was really about how important these in some ways are really secrets, like that if you know, how do you, they're really a good, someone said they're the best kept secrets, the whole COC, and that if you don't know how to engage and how to work with that system, then you're missing an opportunity to really help people. So if you could sort of just talk about, address those things in whatever way.
I would just have to say, given time, if you can address them in maybe 30 seconds, Libby, which is very fair, I'm sure. And then we'll wrap up.
Okay, I'll address the second one first. So a lot of times these are very opaque systems, and you just have to be politely persistent with your COC as you build a relationship with them, and say, oh, just please explain to me, you know, help me understand, like over and over and over again until you and then I had to do about 3 days worth of research before I finally found the algorithm for the VI SPIDAT, which took me a long time, but I found it. But you know, it just be persistent, and the more, and again, you know, once you're an insider and you're part of the COC, you still don't get all the information you need, but sometimes you do. And you can go to, like I said, if you're part of those community meetings, you can be much more assertive about asking those questions. In terms of HMIS, you know, I don't, the most useful thing about HMIS is that it collects comprehensive homelessness demographic data. And so, and that's really useful for your COC to get funding and to kind of know where they're at in terms of the severity of the needs and planning purposes. So for the day-to-day people who are using it, you'll see episodes that people have used shelter services. You know, they were at this shelter for 2 months, or there's a flag on their chart that says they've been banned from all of these places because they assaulted, you know, a staff member, or, you know, things like that. Or sometimes you'll get a flag saying, you know, the housing outreach team is looking for this guy. If he comes in, you know, let them know, that kind of thing. But it's not, there's a lot of information that's missing. You won't know if someone's getting case managed by some agency out there. You won't know if they're receiving mental health care, you know, that kind of thing. Those are some of the limitations in 30 seconds or less.
Yeah. Thanks so much, Libby. That was an unfair time limit for me to put on you, but appreciate you giving actually a really great and helpful answer to both those questions in a very limited time. So I have up on the slide, just as by way of closing up, that we have one more webinar in this series, and it dovetails nicely with that last question because it is related to specifically to HMIS and data sharing across health and homeless systems of care. So moving on from sort of coordinated entry partnerships to the specifics of data. And so there's, you can still register for that. It's a week from today at the same time. We'll also provide, in addition to these slides and a recording link, we'll provide links to, you know, another link to that registration. And these links here are live, including some resources relating to everything we've gone over, both this webinar and the past webinar. And a data report that's contains lots of really, really fantastic information that will be a topic of conversation on the next webinar. So with that, I just want to thank Libby so much for joining us today and providing really great insight into your experience and your program's experience with coordinated entry. Thank you all. Thank you, Michelle and California Healthcare Foundation for this, and Julie for being on here with me, and really appreciate all of you for attending and asking lots of questions. I know we probably didn't get to all of them, but really appreciate you being actively engaged and providing questions. And perhaps on a future webinar, another resource, we'll be able to connect you with some answers to questions that you still have. So thank you again so much to everyone, especially you, Libby, and have a wonderful day, everyone.